Let me welcome all the speakers of the day. So, it's very interesting. We have always had this, view, at least the physicians and the healthcare providers, we've had this view that technology providers, we've always treated them as vendors. But now it's very, very clear that the relationship has to change. We can no longer be a client and a vendor relationship. We have to work as partners. And in this partnership mode, we can look at very successful rollouts. So I'm going to call the first speaker is Mr. Subramaniam. Mr. Subramaniam is a senior technology entrepreneur and has immense experience of more than 25 years in working in healthcare technology, and has been worked in multiple countries. So therefore, I want to just call on him and listen to him.
Thank you very much. It's a pleasure to be, a part of this wonderful event. I have some experience, if not the great experience, as you would say. I would want to share my experiences with you. I've been working on this connected digital health as a very interesting framework where how do we connect the dots to get the service delivery efficiencies. So connected digital health can be at various tiers of the system, whether it's from the primary or the secondary or the tertiary or quaternary, whatever is the level that you're talking about, and how do we connect? And when we connect, we are also talking about how do we connect the doctor, the nurse, the patient, the pharmacy, the diagnostics. So it's a huge network that we are trying to look at. And as an initiative, I have been closely associated with one of the experiences. I just want to share one experience. And that is the experience that we have had where the project was sponsored by Tata Trusts and then later on taken by the government of Telangana to scale. And the idea of the session, as I could understand, was more to do with the rolling out of technology. It's essentially not only having a technology, but how do you do a rollout and what are the success that you could get out of this technology rollouts. So that's the context in which I'm sharing my thoughts. I hope the forum is comfortable with the context or the content that I'm wanting to present. Now, the objective of what we wanted to achieve was of the following nature, that we wanted the primary health context to be connected to the rest of the system. And in doing so, what we wanted to see is what is the way we can give end-to-end services, starting from teleconsulting, visit management, follow-up, counseling, referral systems at the PHC, using technology and primarily bridging the urban and the rural healthcare divide. So the major issues that we were trying to tackle is how do I get the specialist time? How do I, and this is more so in the public health area that we are talking about, not in the private sector, but we are talking in the public sector, public health area. So to that extent, we were also trying to see how do we create a hub and a spoke model for achieving this, and how do we reduce the load of the tertiary hospitals and increase the footfall right at the PHC level for all the specialist consultings that we would want it to do. So this was the primary objective, where we realized that more than, at least this was what was the initial study that was done by Tata Trust, where they figured out that more than 30 to 40% of the consultings that happen at the specialist level do not need the specialist time, and they could have been actually resolved right at the origin, which is either the tertiary or the secondary, which essentially means that people are moving to these places. And when they move to these places, we end up getting into costs involved, out-of-pocket expenses, loss of daily labor wages, so many economic factors affect the entire process. So how do we bring the efficiency there? How do we ensure that the service is provided at that level? That was the first problem that we wanted to solve. And then the second major problem that we wanted to solve is, let's assume you are identified as somebody who needs a specialist one-on-one consulting, not a teleconsulting, but a one-on-one, then how do you help these guys to get to that place? I mean, one of the greatest challenges that we have typically, let's say, for example, I come from Hyderabad and Osmania General Hospital is one of the biggest hospitals that you have. If you just come to the entrance of the hospital, you are lost. You just don't know where to go. And imagine somebody coming from a rural area and he has to go to a specialist chamber, which is on the 3rd floor, 6th block, somewhere at the corner. How do you get there? So how do you help them with all this, visit management and care coordination? How do you ensure that there is a follow-up on whatever happens? All these were also a very important part of the initiative that we were trying to work on. And those were the objectives. Finally, obviously now the, flavor of the season is trying to use AI and ML in terms of analytics and dashboards and see how you could come up with certain predictive inputs and more for monitoring the system and also for research. So that's the overall context in which this project has been taken up by Tata Trust in collaboration with the Ministry of Health, the Government of Telangana. And a very simple model, you have the rural centers, you have the urban centers, then you have a rural hub, you have an urban hub, and how do you connect these guys together? This went through a very interesting transition. The project that I'm talking about is now 3.5 years old. And what we tried doing was in 3 phases. And the first phase was what we call the pilot. And then we went into what is called deepening the pilot. And then we came up with what is called the scale up, which means whatever that we have learned in the deepening of the pilot, which is confirmed, which is now a cookie cutter model, how do we just replicate it and take it across the state? I'm extremely happy to share that this is something that has been done very effectively, very efficiently, both by Tata Trust as well as the Government of Telangana. And what I feel happy is that the Tata Trust has also moved away and the ownership has been taken by the Government of Telangana. Not only that they are doing it at this scale, but they're also integrating it into the eSanjeevani, the project by the Government of India. So there's a lot of integrations that are also evolving in this overall project that has been brought forth, right? So in the pilot stage, what we did was as a very, very simple teleconsulting service, and we had 4 districts, and that's where we started. And we came with a design where we said we will create what is called a collaborating call center, because we needed a broking center. That is how we conceived it right in the beginning, that we said, okay, somebody can call the call center and the call center will identify the doctor or the specialist and then handshake it. And then the process happens and then the consulting happens and so on and so forth. So there was a call center with over 30 to 40 people that was set up. And these people were continuously calling the doctors, calling the specialists, calling the the patients to connect up into simple telemedicine framework. And then we realized that from there on, we had lots of learnings in deepening the pilot and then the scale up, and we found some very interesting results. So the first thing that we did in the pilot stage, what we call the urban davakhanas, is where we set up some basic infrastructure and we call them the virtual hospitals, so that they have almost all the facilities of the hospitals, which can be virtually connected to the tertiary hospital. So that was the first piece, which we call the spoke. And then we went on to the other side where we had the hub, and we had 2 specialties to start with Osmania and the area hospital Sircilla, where we had 6 specialties. And we created one small room where the telemedicine sessions can happen. The doctor can come there or the specialist can come there. And at the PHC, you get connected and so on and so forth. It's a standard telemedicine model that we started, but for what is called the intermittent layer, which is called the HealthX platform that was provided. And this platform was essentially trying to have the call center playing the role of coordination and monitoring, follow-up, and connecting the patient through the doctor to the specialist for a consulting. So that was what was the design that was brought in. And you can see how the whole sequences were happening. The doctor, and then there is a call that is done by the center, so on and so forth. And this is a complete cycle where we are also talking about diagnostics. We are also talking about the medicines to be, dispensed at the PHC under the instruction of the specialist and the doctor. And if there is a diagnostic test that is recommended, if the test is done and you come back into the consulting at a later stage, and this entire follow-up is managed by the call center. So that was the basic idea. But then that call center itself became a very interesting problem, because as the scale increases, the call centers also have to increase. So roll up in terms of the entire innovation, in terms of scale, was a very, very difficult problem. That means as we increase from the first 20, 25 centers, now if we move to 100 centers, 100 spokes, then we need to increase the call center staff. That means it is HR cost. That means training cost, so on and so forth. Then the government was saying that, why don't you look at, learnings from this and see how you can improve it. So that's where we started with the pilot learnings. And in the beginning, we just did only consulting. We didn't do anything. That was the pilot stage. Then the government was trying to see, why don't we look at the entire, gamut of activities, starting from your consulting, follow-up, care coordination, visit management, referral, the whole chain of things to be done. And then they said, let us try to now shift it from this so-called brokered system, from a system perspective, from a person perspective, which is the call center perspective, move it to system-centered mechanism by which bring automated schedulers, automated mechanisms by which this entire synchronizations happen. And that's where I think the major breakthrough came, and this is what happened as a consequence. What we created as a framework of consulting and inquiry, which was the first pilot that we did, we moved the entire technology into consulting, coordination, counseling, follow-up, and electronic health record. All this, along with patient portal and analytics. So you can see the entire platform got recasted in a different way. And that was the very important thing that we needed to put in place for the scale up. And then once we did that, we realized that we had brought in new technologies in terms of screening, brought in technology in terms of schedulers, coordinations. Then we also got into creating a virtual hub, integrations that were previously not there. So all these primary details were brought in, and as a consequence, the deepening of the pilot happened, and it moved to 273 locations. That's what we did. From an initial 20 locations, we moved to 273 locations. That was the first shift that we had. And you can see, whenever we are talking about any scale up, the most important thing that we look at is the robustness of the technology, the learnings that we have got out of using in the pilot and enhancing the pilot to the next level. Then a more important thing is capacity building. Now, initially, we were talking about just running one simple program. Just bring those nurses there, make them sit there and tell them, yeah, do this, click that. That's how we were trying to create and adopt some of the doctors. But then if you want to make it a systemic process by which you want to really roll out across the state or at a larger scale, we realized that this is not going to work. So we created a complete training capacity building portfolio of programs. And these programs were conducted continually at various levels, whether it's for the doctors or the specialists, how to use the technology. And more interestingly, what we created as a platform initially was not mobile compliant. At the deepening stage of the pilot, we converted the whole thing onto mobile compliant, which means that the specialist can just click on it and he's in a position to get into the entire context of the consulting. So these were the additional things that were brought in terms of capacity building. So we had technology change, capacity building change, and then created the required infrastructure, which was very important, that when we wanted to scale up to over 280 PHCs, everywhere you need to provide tabs, printers, desktops, then connectivity, make sure. So these are all the issues that we brought in, and that took us to the next level. And then finally, you can see how much of a change that came in. We had 1,000 teleconsultings per day at the PHC level, 250 teleconferencing or referencing at the sub-center level, and we had 1,000 nurses, 250 doctors. That's the leap that we went in by the deepening from September 20 to September 2021. And then came the most interesting phase, which we call the hockey stick, where now the entire state is covered. All districts are covered. We do roughly 2,000 sessions a day only on specialist consultations. And today, I think we have to really appreciate the way the rollout has been done by the government of Telangana, where they created an incentivization mechanism by which more than 900 doctors participate in providing these consulting services and 20 specialties. Overall, there has been an estimate that was made recently as an impact and a third-party analysis, and we found to an extent of 5 to 6 crores of rupees has been saved just for the patients in their out-of-pocket expenses not being incurred. Just imagine the kind of impact that the project has done and the meaning of such a rollout. I'm just sharing this single initiative. I have had experiences of this in Sri Lanka, where we have done a project. We are currently talking very, seriously at a very advanced stage in replicating some of these stories in Malawi, in Uganda. And we find that the same kind of problems, the same kind of learnings are applicable. And more interestingly, technology as a platform can reduce a whole lot of costs that are involved in it. Like, for example, the call center costs are removed. Now, schedulers being automated, anytime, anywhere, you will be in a position to get your consulting. So these are the things that have actually brought in the need of technology. I mean, I'm just trying to connect to the previous session that we've had, where Mr. Shah has been talking about how the platform has leveraged great results. I think the solution up here that has been implemented by the government of Telangana also has a similar strength. And the joy of this entire experience that we have gone through was to see how a pilot that was designed in a particular way completely changed, became so robust, and has reached out to so many more people and has given benefits of a significant level. I think with those details, I would like to thank for giving me this opportunity to participate in this session. And the greatest success factors that we saw was the participation of the government was very, very sincere. They actually had a nodal officer specifically appointed, and then the project planning and the scale-up strategies were very well discussed. I think that is the scope that I just wanted to discuss with you. Over to Madam Umaji.
Thank you, Mr. Subramaniam. Thank you very much for giving us the results of such a wonderful project. How does this dovetail into the Ayushman Bharat Digital Health Mission project of
this is very much a part of. See, this was initially started as an independent initiative. But then what happened is the government of India also started giving the guidelines as to how it has to go. So once the eSanjeevani solution has been brought in, which was a part of the general consultations, this became an augmented program for the specialist consultation. And now it's got integrated into the eSanjeevani project. It's not lying anymore outside. So what we leverage is both the strengths of eSanjeevani and also the learnings of what all we have done into eSanjeevani.
Okay. But just to conclude the session for the day, I think it's, starting from where Dr. Devi Shetty had very clearly told us as to what is expected of technology, and that is delivery of safe patient care. And that is what, in a rollout, what is that we expect that we have to do. So Mr. Subramaniam very eloquently told us how they have, tried to resolve the question of access and quality healthcare, and also capacity building to match the requirements at the rural space, and then to connect the rural urban so beautifully so that the ecosystem is developed very well. And then for this ecosystem to develop well, what Mr. Ian said, is so logical, is that we have to have a collaborative ownership, stakeholder ownership mindset, and an agility built in not only to the technology, but also the way the healthcare providers look at how we provide healthcare. And Dr. Harsh Mahajan has told us what the journey ahead is going to look like. We haven't even seen the tip of the iceberg. And if digital technology and evolution is, whatever we are seeing right now, the way it is rolling out, it's exciting times for the healthcare providers, because we can expect to roll out healthcare and to provide healthcare in a billion ways better than what we are doing today. And the beneficiaries at the end of the day, it is the patient and the entire health ecosystem and the provider fraternity really taking the lead. And I hope that we are able to take the lead in this journey and be a partner with the technology providers, because we are now the technology providers are part of the provider team and we are on the same side. So thank you very much to all the speakers.